Welcome to the Anatomy Dissection Laboratory for students. In this video, we will dissect the posterior triangle of the neck. The authors of this presentation are Dr. Carlos Suarez-Quian and Joel Walensky. Dr. Suarez-Quian is the narrator. The muscles of the posterior neck, and those that make up its boundaries, are associated with keeping our heads held high and turning it from side to side. One, the trapezius, helps us shrug our shoulders. But now, think of bad posture, having to keep our head focused on a monitor at work, and developing pain in our necks. In addition, the nerves found here, the brachial plexus and the spinal accessory nerve, are involved in moving all the muscles of the upper limb. The boundaries of the posterior triangle of the neck include the posterior boundary of the sternocleidomastoid, the anterior boundary of the trapezius muscle, and the clavicle. Let's start the dissection of the posterior triangle of the neck. We begin the dissection of the posterior triangle of the neck by marking the skin cuts that will be made. In this cadaver, the mortician used a neck site for the infusion of embalming fluids. The neck has layers of relatively thick fascia that function to maintain the integrity of the many structures within it. The most external layer is known as the investing fascia, and it encloses the sternocleidomastoid muscle. In this image, the skin was completely removed and much of the superficial fascia scraped off to reveal a muscle of facial expression, the platysma. The platysma is paper thin and is responsible for making the skin of our necks tighten when we grimace. Indeed, when the cosmetic procedure termed a facelift is performed, the platysma is also tightened to render a taut superficial neck, characteristic of younger individuals. Before the deeper structures of the neck can be demonstrated, it is necessary to reflect the platysma and as much of the investing fascia as possible. Oftentimes, superficial nerves will be reflected along with the platysma, but not in this case. Continuous cleaning of the investing fascia reveals some structures that are located partially within the posterior triangle. First, the sternocleidomastoid is indicated to demonstrate the anterior boundary of the triangle. Next, segments of the tail of the parotid gland, the largest salivary gland, become visible. Two cutaneous veins are now seen, the external and anterior jugular veins. You should be aware that the venous drainage pattern of the head and neck is quite variable, and not every cadaver will express an anterior jugular vein. Many of the cervical nerves that supply the cutaneous regions of the neck and shoulder, responsible for making a neck massage such a pleasurable and relaxing experience, emerge from a location posterior to the sternocleidomastoid muscle that is known as the nerve point or Erb's point. In this image, we can see two of these nerves, the great auricular and the transverse cervical. The nerve point is used to anesthetize the neck for surgical procedures. The plethora of nerves in this region, as well as the high variability of the superficial veins, requires careful dissection in this region. With patience and skill, however, it is possible to say the venous pattern as shown in this slide. For example, note the anterior jugular and external jugular veins coming together to form the common facial vein. This vein carries most of the venous blood from the face. However, blood clots in this vein can reach the cavernous sinus in the skull, resulting in an infection of the sinus with potential fatal consequences. Further dissection reveals the supraclavicular nerves that supply sensory innervation to the shoulder. The supraclavicular nerves are derived from the third and fourth cervical nerves, as is the phrenic nerve, which innervates the diaphragm. Thus, sometimes pain from diaphragmatic or liver disease is felt in the shoulder region rather than in the abdomen. Accordingly, if you're treating a patient with shoulder pain, you need to ascertain whether this pain is really due to a shoulder injury or due to visceral disease. How will you do this? If the patient has a shoulder injury, manipulating the shoulder and or pressing on it should increase the patient's pain, and yes, they will not like you after this. If you do this and the patient does not grimace, you likely need to tell the patient to see their physician. The last nerve of the cervical plexus is now revealed, the lesser occipital nerve. This nerve is responsible for occipital neuralgia, a medical condition characterized by chronic pain in the upper neck, back of the head, and behind the eyes. The main symptom of occipital neuralgia is chronic headache that can last from hours to days. And because chronic headaches are a common symptom of numerous conditions, occipital neuralgia is often misdiagnosed at first. Exploring deep to the sternocleidomastoid muscle, just superior to Erb's point, we begin to see a major nerve, the spinal accessory, or the 11th cranial nerve, as it emerges from the posterior border of the sternocleidomastoid muscle. This nerve innervates the sternocleidomastoid and then enters the posterior triangle of the neck, where it will innervate the trapezius. Because the posterior triangle can be manipulated during the dissection, and the internal jugular vein was manipulated during the embalming, we wish to point out that it too can now be observed in this slide. In the living, the internal jugular vein is found within the carotid sheath deep to the sternocleidomastoid. Additional cleaning shows the spinal accessory nerve traversing the entire posterior triangle as it heads toward the trapezius muscle to innervate it. Injury to the nerve within the posterior triangle results in a loss of function of the trapezius and thus a deficiency in shoulder and arm upward rotation. Indeed, a simple test to assess functionality of the nerve is to ask patients to shrug their shoulders against resistance. An injured nerve prevents patients from shrugging their shoulders. Finally, removal of all the investing fascia reveals the floor of the posterior triangle, which is comprised of the splenius capitis and cervicis muscles. This now concludes the dissection of the posterior triangle of the neck.